Hi, I'm Dr. Dave. Let's talk a little bit about mitral valve stenosis. Mitral stenosis is a valvular heart disease characterized by the narrowing of the orifice of the mitral valve of the heart. In normal cardiac physiology, the mitral valve opens during left ventricular diastole to allow blood to flow from the left atrium to the left ventricle. Blood flows in the proper direction because during this phase of the cardiac cycle the pressure in the left ventricle is lower than the pressure in the left atrium, and the blood flows down the pressure gradient. In the case of mitral stenosis, the valve does not open completely, and to transport the same amount of blood the left atrium needs a higher pressure than normal to overcome the increased gradient. Most cases of mitral stenosis are due to disease in the heart secondary to rheumatic fever and the consequent rheumatic heart disease. Less common causes of mitral stenosis are calcification of the mitral valve leaflets, and as a form of congenital heart disease. However, there are primary causes of mitral stenosis that emanate from the cleft mitral valve. Other causes include bacterial endocarditis where the vegetations may favor increased risk of stenosis. The normal area of the mitral valve orifice is about 4 to 6 cm². Under normal conditions, a normal mitral valve will not impede the flow of blood from the left atrium to the left ventricle during ventricular diastole, and the pressures in the left atrium and the left ventricle during diastole will be equal. The result is that the left ventricle gets filled with blood during early diastole, with only a small portion of extra blood contributed by contraction of the left atrium, the atrial kick, during late ventricular diastole. When the mitral valve area goes below 2 cm², the valve causes an impediment to the flow of blood into the left ventricle, creating a pressure gradient across the mitral valve. This gradient may be increased by increases in the heart rate or cardiac output. As the gradient across the mitral valve increases, the amount of time necessary to fill the left ventricle with blood increases. Eventually, the left ventricle requires the atrial kick to fill with blood. As the heart rate increases, the amount of time that the ventricle is in diastole and can fill up with blood, called the diastolic filling period, decreases. When the heart rate goes above a certain point, the diastolic filling period is insufficient to fill the ventricle with blood and pressure builds up in the left atrium, leading to pulmonary congestion. When the mitral valve area goes less than 1 cm², there will be an increase in the left atrial pressures, required to push blood through the stenotic valve. Since the normal left ventricular diastolic pressures is about 5 mmHg, a pressure gradient across the mitral valve of 20 mmHg due to severe mitral stenosis will cause a left atrial pressure of about 25 mmHg. This left atrial pressure is transmitted to the pulmonary vasculature and causes pulmonary hypertension. Pulmonary capillary pressures in this level cause an imbalance between the hydrostatic pressure and the oncotic pressure, leading to extravasation of fluid from the vascular tree and pooling of fluid in the lungs. Congestive heart failure causing pulmonary edema. The constant pressure overload of the left atrium will cause the left atrium to increase in size. As the left atrium increases in size, it becomes more prone to develop atrial fibrillation. When atrial fibrillation develops, the atrial kick is lost, since it is due to the normal atrial contraction. In individuals with severe mitral stenosis, the left ventricular filling is dependent on the atrial kick. The loss of the atrial kick due to atrial fibrillation can cause a precipitous decrease in cardiac output and sudden congestive heart failure. Patients with mitral stenosis prompts a series of hemodynamic changes that frequently cause deterioration of the patient's clinical status. A reduction in cardiac output, associated with acceleration of heart rate and shortening of the diastolic time, frequently leads to congestive heart failure. In addition, when AF sets in, systemic embolization becomes a real danger. In most cases, the diagnosis of mitral stenosis is most easily made by echocardiography, which shows decreased opening of the mitral valve leaflets, and increased blood flow velocity during diastole. The transmitral gradient as measured by Doppler echocardiography is the gold standard in the evaluation of the severity of mitral stenosis. Another method of measuring the severity of mitral stenosis is the simultaneous left heart catheterization and right heart catheterization. The right heart catheterization, commonly known as Swan-Ganz catheterization, gives the physician the mean pulmonary capillary wedge pressure, which is a reflection of the left atrial pressure. The left heart catheterization, on the other hand, gives the pressure in the left ventricle. By simultaneously taking these pressures, it is possible to determine the gradient between the left atrium and right atrium during ventricular diastole, which is a marker for the severity of mitral stenosis. This method of evaluating mitral stenosis tends to overestimate the degree of mitral stenosis. However, because of the time lag in the pressure tracings seen on the right heart catheterization and the slow Y descent seen on the wedge tracings, if a transeptal puncture is made during right heart catheterization, however, the pressure gradient can accurately quantify the severity of mitral stenosis. The treatment options for mitral stenosis include medical management, surgical replacement of the valve, and percutaneous balloon valvuloplasty. Mitral stenosis typically progresses slowly, over decades, from the initial signs of mitral stenosis to NIA functional class II symptoms to the development of atrial fibrillation to the development of NIA functional class II or IV symptoms. Once an individual develops NIA class II or IV symptoms, the progression of the disease accelerates and the patient's condition deteriorates. The indication for invasive treatment with either a mitral valve replacement or valvuloplasty is NIA functional class II or IV symptoms. Another option is balloon dilatation. To determine which patients would benefit from percutaneous balloon mitral valvuloplasty, a scoring system has been developed. Scoring is based on 4 echocardiographic criteria: leaflet mobility, leaflet thickening, subvalvar thickening, and calcification. Individuals with a score of AN number 8805-8 tended to have suboptimal results. Superb results with valvotomy are seen in individuals with a crisp opening snap, score less than 8, and no calcium in the commissures. Thank you for listening. Goodbye.